Welcome along to the deep dive. Today we're digging into something really quite stark, a pressing challenge, why tens of thousands of children in Zimbabwe aren't getting their basic vaccinations each year. Our mission really is to unpack the latest data. We've got the WHO and UNICEF's estimates of national immunization coverage. That's the WUENIC report, just out July 15th, 2025. And we'll fold in expert views, look at what's happening on the ground, try to get the full picture. Because, this isn't just stats. It's about real kids, real families, and a complex mix of, well, challenges, but also some real progress, too. Okay, let's unpack this and get to the heart of what's happening. Let's start right there with that headline number from WUENIC. Around 34,000 children in Zimbabwe going without basic vaccinations every year. Just pause on that. It means they have zero protection against some really dangerous but preventable diseases.
Yeah, and when we talk about these kids, a key term is zero dose. These are the children who haven't even had the first shot of the DTP vaccine. That's diphtheria, tetanus, and pertussis, DTP1. And this isn't just Zimbabwe. It's a regional thing that's quite alarming. Across southern Africa, the number of these zero-dose children has jumped to 948,000, a really sharp rise from the year before. Now, for Zimbabwe specifically, that WUENIC report puts their 2024 DTP1 coverage at 93%. And okay, 93% sounds high, right? And it is relatively good in context. But that gap, the other 7%, well, that's your 34,000 kids. That's what we're talking about.
So what does this actually mean for these children? I mean, beyond just saying they're susceptible, what's the real immediate danger for them?
It means they're completely exposed. It's not just a theoretical risk. They're vulnerable to diphtheria, tetanus, pertussis, obviously, but also measles, polio. I mean, a whole range of diseases we can prevent. Missing that first foundational vaccine just leaves them wide open from the very start. It impacts their health naturally, but also the whole community's health, public health overall.
Okay, we see the scale, that gap, those 34,000 children. But the big question, the one we need to really dive into, is why? Why are they being missed? What's going on underneath?
Well, Dr. Ruto Chikator, who's UNICEF Zimbabwe's health specialist for immunization, points to three big interconnected reasons. First off, geographic inaccessibility. Simple, but huge. You've got poor roads, areas that flood and become impassable, and just massive distances to the nearest clinic. Think about places like Binga, Gokwe North, and Boyer districts. Really tough terrain. And it's not just rural isolation. Informal settlements, near cities and border communities often face similar access barriers.
Right, so getting there is the first hurdle.
Exactly. The second factor is vaccine hesitancy. This comes from a few places. Sometimes it's misinformation spreading. Sometimes it's specific religious objections. Other times it's a low perceived risk. People haven't seen measles or polio for a while maybe, so they think, oh, it's not really a threat anymore. Complacency creeps in. But here's something Dr. Chikodzor flagged as particularly worrying. There's a growing trend of vaccine resistance among more affluent urban communities.
Really? That's surprising. You maybe expect the opposite.
You would. Traditionally, uptake was high there. It suggests the reasons are shifting, maybe becoming more complex than just lack of information or poverty. It requires a different kind of conversation.
Okay, so that's a really key point. How do you even begin to tackle that? If it's not about access or basic info, what kind of approach works for, say, urban hesitancy versus rural hesitance?
It absolutely needs a different strategy. For those urban groups, maybe it's more targeted engagement, perhaps through social media, working with different kinds of community influencers, addressing very specific concerns with clear evidence. It's less about just getting the service to them and more about tackling specific anxieties or maybe even ideological objections head on. Very different from ensuring a remote village even have access to a cold vaccine. And the third big driver Dr. Chikadzor mentions, transient lifestyles. Think about populations like artisanal miners or contract farm workers, informal traders, people constantly on the move. Following a vaccination schedule is incredibly difficult if you're not in one place. They just miss appointments because, well, they've moved on.
We actually have a quote here that brings that accessibility challenge right down to the ground level. This is from Sister Caritas Mbame. She's the district nursing officer for Gokwe, she said. On the issue of zero doses, as a district, we have realized that because of the vastness of the Dishna versus the number of facilities, most of our communities are not able to come to the facilities, including vaccinations. We also realized that we reach more communities through outreach activities. We hope that the zero doses are going to reduce because the facilities are now conducting more outreach activities. Hearing that directly from the field, from someone like Sister Mbame, what does that tell you about where the focus needs to be for support organizations?
It tells you everything, really. Sister Mbame's words hammer home that just building a clinic isn't the whole answer. It's not build it and they will come. It highlights the absolute need for proactive outreach, going to the communities. So for organizations like UNICEF, WHO, Gavi, it means doubling down on mobile health teams, supporting those vital community health workers who live in these vast areas. And it means sorting out the logistics transport, keeping vaccines cold on the move, bringing the service directly to people instead of just hoping they can overcome huge barriers to reach a clinic. Meet them where they are. Let's look a bit closer at Zimbabwe's numbers from the WUENIC report. We mentioned the 93% DTP1, but for the full DTP3 series, all 3 doses coverage drops to 84%. That leaves about 48,000 kids still not fully protected, vulnerable to things like measles, even if they got the first shot. And for the first dose of the measles vaccine itself, it's 90%. Good, but still a 10% gap. What's really stark, regionally, is that no country in Southern Africa hit the 90% target for all the core childhood vaccines. The whole region remains vulnerable to outbreaks because of these gaps.
Okay, but despite all that context, despite the clear challenges, Zimbabwe is doing relatively well on that first DTP1 dose, right? So 93%, only behind Botswana and Malawi in the region. So what are they doing right? Is there a secret sauce here?
It seems to be a combination of things, working together quite effectively. First, there's genuine high-level political commitment. It's not just lip service. The government consistently prioritizes the expanded program on immunization, the EPI, in its health plans. Second, they make really good use of existing structures, especially the village health worker networks. These people are known, trusted in the communities, and they use school-based platforms too. Third, they've integrated immunization smartly into primary healthcare and maternal child health visits. So a mom brings her baby for a checkup, they can get vaccines at the same time. Makes it easier. And fourth, there's been consistent support from partners UNICEF, Gavi, WHO over many years. That long-term investment builds capacity and trust. All that together seems to have built a pretty strong foundation of community awareness and, crucially, trust in the system.
That makes sense. That integration piece, using village health workers, it sounds sustainable. But you mentioned partner support. How critical is that continuous external funding, especially if Zimbabwe faces other economic pressures? Is one of those factors, like the absolute key?
That's a great question. While all pieces matter, I'd argue the integration into primary care and the strength of the village health worker system are probably the linchpins for long-term sustainability. Why? Because they rely more on existing national infrastructure and trusted local people, rather than just short-term projects funded from outside. Partner support is, of course, absolutely vital for things like vaccine procurement and technical expertise, but building those resilient national systems means the work can carry on even when specific grants end or funding levels change.
Okay, it's definitely a complex picture with serious challenges, but let's flip to the solutions. What's being done? What are the strategic responses, the innovations happening right now?
The Ministry of Health and Child Care, through their EPI department, is really tackling this on multiple fronts. They started by digging deeper into the why. For instance, doing a gender barrier assessment last year in districts with high numbers of zero-dose kids. Understanding if, say, mothers face specific obstacles. Operationally, they're pouring resources into 33 high-burden districts, boosting both community outreach and support at the clinic level. Setting teams out, they've introduced a clever performance-based demand creation model, basically giving incentives to local gatekeepers, maybe community leaders, to actively encourage families to get vaccinated. And there's a really neat innovation called the My Village, My Home model. It's essentially a local tracking tool. Village heads and health workers use it to identify kids who've missed shots and then personally follow up with the caregivers. Very grassroots. To beat the access problem, they're getting creative with transport. Tricycles, all-terrain vehicles, even mobile vans to handle rough terrain. Plus, they're actually building new health posts closer to where people live, cutting down those long travel times. And absolutely critical for vaccines, the cold chain. They're rolling out solar-powered vaccine fridges, especially in rural off-grid areas. This ensures vaccines stay effective, which is a huge logistical challenge. Their communication isn't just generic posters either. It's guided by human-centered design, really understanding community perspectives, using specific behavioral data from 19 priority districts.
And UNICEF is right there alongside them, right? Working closely with the ministry and others.
Absolutely, hand in glove. UNICEF often focuses on bundling services. So during child health days, a child might get the routine vaccines plus vitamin A, deworming treatment, maybe other health checks all in one go. It makes the trip more worthwhile for parents and catches those zero-dose kids who might be missing all health services. They heavily support those mobile outreach teams, often staffed by or working with community health workers. Data is key for UNICEF too. They support data-driven micro-planning using tools like DHIS2, that's a health information system, to map exactly where the zero-dose children are, down to the village level almost. This allows for super targeted outreach. And they invest a lot in demand generation, using social and behavior change strategies, dialogues with parents, involving traditional and religious leaders who hold sway in communities. Plus, big investments in strengthening that whole EPI supply chain, more solar fridges, training for maintenance, ensuring the whole system works smoothly. Dr. Chigozora actually summed this up nicely. She said, and I'm quoting her insights here, "Yes, several innovations are currently being implemented. The My Village, My Home tracking tool is used by VHW's village health workers to monitor vaccination defaulters, to improve vaccine storage and delivery. UNICEF has supported the procurement of solar-powered refrigerators and tricycles, bundling services like HPV vaccine, tetanus diphtheria booster, nutrition services, ensures a comprehensive package is given for the zero-dose children, as they are children who are also deprived of other health services." You see how it all connects: tracking, access, cold chain, bundled services. And underpinning a lot of this is a framework used by UNICEF, Gavi, and WHO called the Gavi-ARMA framework. It stands for Identify, Reach, Monitor, Measure, and Advocate. Think of it as a structured approach. Identify every child, reach them with vaccines, monitor the progress, measure the impact, and advocate for the policies and funding needed. Gavi, in particular, provides crucial funding for buying vaccines and technical support.
Okay, so lots of activity, lots of strategies being deployed. Looking forward, then, what are the big opportunities to build on this momentum? And conversely, what are the major roadblocks still standing in the way?
Dr. Chikoto pointed out some real opportunities. One is taking things that worked well for specific campaigns, like the HPV vaccine drives, often done through schools, and adapting those successful models for routine childhood immunizations. Another is leveraging Zimbabwe's move towards devolution, giving more power to county-level leadership. This could help tailor programs even more closely to local needs. And there's potential to tap into global funding streams, like the Pandemic Fund, or specific Gavi grants for strengthening health systems. But the challenges are serious. A big one is the trend of declining overseas development aid as Zimbabwe moves towards middle-income status. That funding has been crucial. We're also seeing growing inequity in informal urban settlements. These areas grow so fast, services often can't keep up, creating pockets of unvaccinated children right near cities. And the persistent issue of health worker shortages puts a strain on everything. You can have the best plans, but you need the people on the ground to deliver the services consistently.
Right. So wrapping this up, it feels like Zimbabwe is at a really critical point. You see this impressive progress, strong government commitment, innovative partner responses. But at the same time, these deep-rooted challenges remain: getting to remote areas, tackling hesitancy that's becoming more complex, reaching mobile families, and now potentially funding pressures. It's a real balancing act.
It is. And if you zoom out again, think about that global goal, the Immunization Agenda 2030. It aims to cut the number of zero-dose children in half by the end of this decade, compared to 2019 levels. For Zimbabwe, for Southern Africa, reaching that goal means, well, urgent, sustained action, continued investment, and really deepening that community engagement, building trust. It really poses a fundamental question, doesn't it, for any nation? For the global community, what does it actually take to reach every single child with something as basic, as life-saving as a vaccine, especially when the barriers are tangled up in geography, economics, and human behavior itself?
And maybe a final thought for you, our listeners, to take away. Just imagine the ripple effect if every child was fully